I can't begin to tell you guys how excited I am about hosting this particular crisis jam. As I mentioned a little bit earlier, this particular jam touches me in a very, very deep way, because we've been talking quite a bit through NASPID and other organizations with regards to servicing our youth and making sure that as we implement 988, we pay particular attention to the needs of the youth and young adults. So I'm happy to be hosting today, and we're going to be talking about it through the Healing Through Justice, as you see on your screen here. We'll talk more in detail about what that all means, but I just want to let you know that today's services are really going to be looking at how we take care of this particular group of individuals as we are in the realm of implementing our trauma in terms of our 988 implementation. So let's go to the next slide, please. As you see here from the statistics, we are progressively moving upward. We're now to 71 national organizations. As you can see, we're 3,178 strong in terms of organization and people involved. We also have both national and international involvement. And as you can see, we still have the top hitters that are going on through YouTube and Zoom, still characterizing that July date as the heavy hitter here. So we're seeing ever increasing involvement through the Crisis Jam, and we're still encouraging those who don't see your organization listed here and you'd like to be a part of it, please get in contact with us. Let us know. We'll be happy to add you to that list. For those that wish to participate in it, you can go through the talk.crisisnow.com and sign up for it. Karen will place in the chat box all the information you ever wanted to need to know in terms of signing up for it. And we're really looking forward to adding to this list and continuing to have it grow. We've moved now over into a new round now. We're starting to look at what things uniquely are working towards implementation and how states are doing and how organizations are doing. If the Crisis Jam has disappeared from your calendar, don't fret, because here you have several possibilities of linking. You can use and click on the spot to go in and do your changes, or you can go into the actual site itself, the website. You can make changes. Or you can go into your chat box, because Karen has also listed in the chat box a way for you to establish a link so that you can put it back onto your calendars. And Karen, I will tell you, from me to you and the several hundred people that are out there, I still need to do that at the close of this session. Okay, next slide, please. All righty, this is a reminder again of our talk.crisisnow.com website. It is filled with information that it goes both backwards as well as forward. So if you are looking at the site and it is something that you're looking at where you want to look at any upcoming events, you can find them on the site. If you are looking to sign up for sites, you can see where there's a link where you can sign up to get reminders or get our newsletter, as well as looking at any previous Zoom presentations of JAM that we've had in the past. So you can then get on the site there. We also, on the JAM highlights, also understand that you can also go backwards and take a look at some of the sessions that have occurred before, because these are really tied in together in a forward-moving fashion. So it gives us the understanding that we're really moving in accordance with what is happening every day. So it's updated constantly, and it gives you the opportunity to see not only some of the facets of the Crisis Jam, but see what new information is available out there for each and every one of us. So access that site when you have an opportunity. And let's go to the next slide. I just wanted to highlight this from SAMHSA, just as a highlight for what is going to be occurring a little bit later. If you're unaware, the Department of Health and Human Services through SAMHSA produced the new national guidelines for improving youth mental health crisis care. And we're going to have a talk on this later in January, but I just wanted to highlight it for everyone to see at this point in time again, from what I said when we first started this all, is that attention is being paid to our youth mental health services, because all of us know the statistics, and we'll get a lot more detail than I'm able to give you at this point in time. Let's move to the next slide, please. All righty, and this slide actually comes from the American College of Emergency Physicians. And Karen's going to put in a link in here, but it's kind of establishing the obvious here, because as we look at 988 implementation, we are looking at how important that's going to be, because our emergency rooms are flooded. And you can look at the flooding from multiple capacities, which doesn't help the system, because as the emergency rooms begin to fill, they are also filling with individuals that are in need of crisis mental health care. And yet they are unable to get that. We have a lot of bordering. We have a lot of individuals that spend large periods of time in the ER when services could be available. So it's kind of a promotion from the emergency physicians to say that we have a crisis that 988 can really make a dent in and really help them out in a supportive way. Next slide, please. Now, this is a particularly disturbing study, as I saw it just a couple of days ago when it was first posted from the Washington Post about the new explorative piece on Yale University, where there were a number of suicidal students who were pressured by Yale to actually withdraw from the facility and then had to reapply. And all of us can imagine what that does. Because what it does is it takes individuals who otherwise may have disclosed about their mental health issues or suicidality to now just not say anything at all. This is a horrible piece here, but it is something that we unfortunately have to contend with here in 2022. And let's move on to the next slide. And I just want to give you this real quick quote from our Assistant Secretary, Dr. Delphin Whitman. The U.S. is facing a mounting mental health crisis, and it's crucial that people have somewhere to turn when they're in crisis, and equally important, that they can speak to someone in their preferred language. This is something we're going to be moving a lot more forward with because the language has become a piece that the states have listed as an important strategy to move forward with. Next slide, please. And we've now reached our featured presentation for today. And this is going to be Healing Through Justice. And at this point, I'd like to introduce to you our speakers for today. And I have my sheet in front of me here. We have three wonderful speakers that are going to be talking to us today. Dr. John Walkup. We're also going to hear from Raul Botello and from Jenny Arwade. And I want to make sure that they have their time to talk. So at this point, I'm going to turn it over to Raul to begin.
Thank you, Brian. Can audio check? Can everyone hear me? Great. Thank you, Brian, for inviting us to speak to your wonderful team. So our organization, Healing Through Justice, the initiative is called Healing Through Justice, but for the vast part of our organization's mission has always been to do civic engagement of young people in Chicago. Over the years, what was occurring with our organization is that we found out that actually our organization was really looking at not just the civic work that our young people have been focused in their communities, but also a lot of the youth development and resilience that was taking place with young people. We were kind of capturing a new kind of eco space that where youth development is intersecting with mental health, and not only that, but the recovery aspects of the work. And in such that, our partnership with Lurie Children has been kind of innovative and really tremendous. We just received WK Kellogg's Racial Equity Award, Global Award for $10 million over 8 years, partly because of the strategy has very promising potentials. Next slide. So the work is really founded on the lived experience of young people. As I mentioned, We started as a trauma-informed organization, civically engaging our young people. But over the years, we realized that not only working with young people to really live their their kind of their aspects of what they would like to see in their communities, but really transforming their identities through this process of not just recovery but action. So a lot of our young people work on issues that impact not only themselves but also their families and their communities. Next slide. So, Dr. Walkup, can you speak a little bit about the partnership? But so essentially, our partnership has been with Lurie Children's for the last probably the last 10 years. But Dr. Walkup, can you speak a little bit about why this partnership is so important to Lurie Children's?
Yeah, I think for most children's hospitals, we usually have three big missions: clinical care, research, and training the next generation of providers. But the other thing that's important is we live in the community and we care for the kids who live in our community. And so it's very important for us to reach outside of our hospital boundaries and engage groups out there that are relevant and important to us, and to learn from them about how we can best serve kids in the community. So this partnership with Communities United really is a partnership with a key community stakeholder, Communities United, that has been invested in the community for 20 years, particularly in communities that have been the hardest hit by racism and poverty, and working with us to think about how best Lurie Children's can stretch itself to do what it needs to do to meet the needs of the kids in those communities and other communities in Chicago.
Thank you, Dr. Walkup. Next slide. So our collaboration with Lurie Children's has, as I mentioned, has been since 2011. And part of the work that young people do is that they not only identify research as an entry point for their civic engagement, but really look at the partnerships with hospitals that are centered in the lives of young people. And so a lot of the policy changes and recommendations that the young people have done over the years have translated to real outcomes in terms of measurable outcomes in the community in terms of public health for our young people. Next slide. So what is healing through justice? Jenny, you want to take that one?
Sure. So healing through justice is, again, as Raul mentioned and Dr. Walkup said, it's an approach that emerges out of our 20 years of work with young people around youth development and civic engagement. And really what it is a youth-led movement for healing from trauma. And a big focus of this work is reframing narratives of young people of color who have been harmed by systemic racism, and promoting healing through community-led action. And this is through a very rich and dynamic process that occurs through the development of young people and really uncovering root causes of systemic racism and how that impacts their communities, and actively working on developing youth-led solutions and putting those into place. Next slide, please. Go ahead.
Go ahead. So young people have been at the center of our work, as I mentioned earlier. But this quote is from our young organizer, and she comes from the community. So she was a young person that got involved and then became an organizer. So a lot of our young people have come through the pipeline. They go off to college, but really want to come back to the community because of their lived experience and changing the process that how young people are engaged in their community, particularly because a lot of the engagement on a lot of youth development or other agencies, public agencies, are really about treatment. Our organizations, while we recognize that treatment is needed, really we focus on the transformation of those individuals in making change within themselves, their peers, and their community. Next slide.
So for one of the projects that we did with Lurie Children's Hospital was a 2-year-long youth-led participatory research project that occurred throughout the pandemic. And it was through our Ujima project focused on young men of color. And the learning question that the boys and young men of color came up with are, what are the challenges we face and what are the resources we need to support our mental health and well-being? Next slide.
So as I mentioned earlier, part of our partnership with Lurie Children's has been at the center that, how do we decentralize, who the experts are in terms of research, right? An example of this is this particular report is that Lurie Children's really provides the technical support for building capacity in our community to have those young people be researchers. So a lot of the work that goes into that is it's very dynamic, it's really intensive, but the outcome is really transformative, right? Because then the research is really is done by the community members, particularly young people. In this one, it was boys and young men of color. So they really do an extensive process for researching their own issues, and particularly issues that impact mental health.
Next slide.
And as we mentioned, that the assets or the way we approach this is really creating not only safe and brave spaces for our young people, but because we don't come at it from the perspective of treatment, we come at it from the perspective of building heroic communities, particularly with young boys and women of color. So we have to create those spaces and processes for really their narratives to really for them to share. That's for young men, that's a challenge in itself. So what we create is these particular spaces that are transformative. Next slide. Do you want to take that one?
Sure. So an example of some of the themes and findings that came out of this research. So in terms of mental health challenges among young men of color, 66% of the young men of color surveyed, and again, this was surveying that was developed and implemented by the young men themselves out in their broader community of peers. 66% reported that they're facing mental health challenges, and 52% of those youth, faced that they had 2 or more concerns with their mental health. Additionally, the young men of color surveyed saw a deep connection between the systemic inequities that they were facing in their communities and mental health. And oftentimes that blame was internalized within them. And that speaks back to what we spoke about earlier regarding really changing the narrative within individuals as well as communities and systems. Next slide, please. Additionally, another really important theme was that young men of color want to be seen for their assets, for the assets that they bring to their communities and their city. And so they really identified how there's such a big difference between the narrative they see about young men in our city of Chicago and across the country that's created by media and society in general, and how the young men of color view themselves and want to view themselves. And they really want to be viewed for their full identities and potential for leadership. And this goes back to, again, a core philosophy of our program, which is, to our work around healing through justice is always coming through an asset-based lens. Young people are often blamed for the problems facing their communities and are really seen as for their deficits. And so we take a pretty dramatic shift. We work with young people who have experienced a lot of trauma, but again, they're really seen for their assets and their leadership potential. Next slide.
So the goals for
Okay.
The goals for our partnership with Lurie Children's on this Healing Through Justice Breakthrough Initiative is really looking at the outcomes that are impacted by trauma, right? And how young people could really recover that, but more importantly, transform their lives and those of their communities. This new model, we're trying to scale it up in many ways. So activities are going to be very much around, the need to create new tables and new partnerships to expand this work. But essentially, this is really kind of a breakthrough initiative that we hope that the public institutions can learn from and replicate in many ways the aspects that we're doing right now. Next slide.
And so we have a theory for change for Healing Through Justice. That's really a shared theory of change between Communities United and our Healing Through Justice initiative and Lurie Children's Hospital. And that's really exciting for us as we embark on this journey because, very rarely have we been in a situation where we're able to, again, put young people at the center of developing a shared theory of how they want to see change, specifically within mental health and addressing issues of systemic racism and inequity in their communities with such an influential health institution. So we're really excited about this. And so our theory of change really puts youth and community at the center of everything in terms of ensuring that their voices and leadership are informing and determining and making real decisions on all aspects of the work that we're doing. And revolving around that is our process around youth healing and leadership, engagement of the broader community and working on broader community leadership, where young people actually take the skills they learn into their communities to be able to create healing spaces and galvanize, the broader community towards action as well to address injustices. And healing-centered mental health, where we're able to actually work towards systems change. And so young people are actively working with Dr. Walkup and his team at Lurie Children's around rethinking the mental health system and how it's serving young people in Chicago. And that piece around not only taking action, but then working towards real tangible changes that can be felt in the lives of young people is key to the approach. And revolving around all of that is really the work around the long-term narrative changes and the creation of truly racially just systems that we seek through the work. And we also hope, we've seen this at a smaller scale, but by expanding to a larger scale, really bringing this work of healing-centered communities where young people and community members are equipped with the leadership opportunities to really reimagine how kind of mental health is supported and healing. Next slide, please. So there have been a number of articles we can send around that feature the young men of color and the young women of color involved in our work. And with that, we can send those around, but I'm going to pass it now to Dr. Walkup, who's quoted at the bottom of the slide and also will take us on from here.
Yeah, this is next slide. So we all know about acute trauma, and we're all kind of tuned in to kind of historical trauma and past trauma that many communities we live and work in have experienced. And I think we have a very good understanding of why trauma persists. And a lot of it has to do with pre-existing challenges or vulnerability, proximity or ongoing experience of trauma, either physical or psychological. And then really what the environment, how the environment has been transformed after the trauma that kind of perpetuates that traumatic experience. But it's also important to note that healing is the natural outcome of traumatic experience. Not everyone who has been traumatized has PTSD. People find a way to rebuild their lives and go on to do something either heroic or transcendent, to really make something out of their life in a way because of what they've experienced traumatically. Next slide. So that idea that there is an initiating trauma or a systemic problem that really impacts people in a negative way, people are obviously victims of that experience, but at some point or another, when the best outcomes occur, is people transition to a place of survivorship or survivorhood. And then what's really cool, and what we've learned in working with youth and healing through justice, is they go through a process of healing at that individual level. They and their families begin to experience healing at the family level. And their work as social justice advocates really begins to help their community heal from the systemic racism that they experience personally within their family and within their community. That idea that that's the natural outcome is really something we want to make intentional with every youth-facing group. The idea that you're not stuck with your trauma or as a survivor, but that those experiences can be really transformative for you and force you on some fundamental level to grow in a powerful way, to heal yourself and to heal your family and community. Next slide. Questions and comments?
Well, first and foremost, thank you all. Thank you all. This is phenomenal. This information is so incredibly helpful, because it opens the lens that we can see in the chat box. Really has to do with nothing about us without us. You put them in the middle of everything that you're doing. And all we've seen is that that has wonderful outcomes. So thank you to each and every one of you. I want to move quickly over to our roundtable. We have two distinguished individuals who are going to be guiding us for the next few moments. We have Eric. Dr. Eric, I don't want to butcher your last name, sir, so I'm just going to say he's a former health counsel with the U.S. House of Representatives, and Dr. Richard McKeon with the branch chief for suicide prevention branch of the SAMHSA. So, Dr. Eric, if you want to start, sir.
Yeah, thanks for having me. So, like Brian said, my name is Eric Rothling-Huon. So I want to leave everyone with 3 comments from the presentation we just had. So the first one is that I really appreciate sorry, my cat's jumping around. The getting rid of the barrier between in the hospital or the clinic and the community. And so this does 2 things for us. One, we actually all live where we live. We don't live in a hospital room. And so the focus on making sure that the communities we're in is healthy and have access to resources, I think that's something that we should encourage wherever we can. The second point is that the way systemic racism manifests in systemic inequities often is in mental health outcomes, and as mental health professionals, that's what we see. But so often, and as the presenters and the youth participants highlighted, it's not really something that can be fixed by treatment, and it really needs focused change in advocacy and community building. And I guess the last point is that I really appreciate the purposeful goal that the presenters and the research team had of making sure that the project that they did with the youth was enabled them to develop leadership skills, advocacy skills, community building skills, mental health skills, whatever it is, and it wasn't just extractive. And that's something that I see a lot in the research world, and I think that's something that we can all learn from.
Well, thank you, Eric. Dr. McKeon?
Sure, thank you for inviting me. Let me just preface my comments with 2 things. One is that I'm really a poor substitute on this panel for my colleague, Brandon Johnson, who is really one of the nation's experts on suicide among youth of color and has helped lead a number of SAMHSA efforts in that regard. I also want to acknowledge my own old colleague, John Walkup, who John and I worked together when he was part of the Johns Hopkins Center for American Indian Health and did some of the most innovative work in the country on suicide prevention in a tribal community with the White Mountain Apache tribe that to this day really has some of the best data on effectiveness. So moving to this specific presentation, I really want to emphasize the importance of this within the current context in terms of suicide in the United States. The preliminary 2021 CDC data showed an overall 4% increase in suicide. But among males aged 15 to 24, it was an 8% increase. And so the highest among any age and sex grouping. But additionally, when we at SAMHSA look at the CDC data in their Wonder system, it appears to us that when you look at youth of color, that it's even greater than that 8% is for males. So our understanding more how to better prevent those tragic deaths, as well as paying attention to suicidal ideation and non-fatal suicide attempts as indicators of tremendous distress that we need to pay attention to. So, with that, just two other comments. I think one of the things that looks really great about this program is the level of both youth and community engagement. And I think youth engagement is absolutely key. The literature on suicide prevention, for example, in schools, shows, for example, it's not sufficient to just train all the adults. The youth have to be engaged in assisting, in working to keep themselves and their other students safe. And those things that have been most effective have been ones that have done that. Things like sources of strength, or the YAMS model that has been used in Europe. And then, of course, community engagement and the need for stronger infrastructure and increased efforts at helping communities work to prevent suicide among their youth is a critical issue. SAMHSA's Garrett Lee Smith State and Tribal Youth Suicide Prevention Grants certainly encourage treatment and engaging people in treatment, but also focus on communities. And one thing we're looking at across the U.S. Department of Health and Human Services is how do we build the community infrastructure in all kinds of communities to help prevent suicide. So a wonderful presentation, very glad to learn about this work.
And thank you, Dr. McKeon. And just to the entire group, again, thank you so much. The chats in the chat box are extremely supportive and are looking at those pieces that you highlighted to indicate to all of us the need to really connect and make that established connection a part of how we move forward. So just all the best to your organization. I'm sure there will be others that will be reaching out to you. There have been some chats in the box about connecting to services that sound similar, that are trying to work with the same lens, but all of them say what Dr. McKeon and what you all have said so wonderfully is that to make that direct connection, establish that collaboration, be able to work both with the youth and the communities are the huge steps there. So thank you for making that point to us all today, but also stressing the importance of it being a very timely topic, because this is what we're seeing also in the chat box is that this is the time we need to be talking about it. During the implementation phase of 988, this is extremely important if we are going to engage our youth into these services. So to each of you, thank you so much again. And we really appreciate your being a part of today's crisis jam. And I think we'll move ahead to our next slide, please. This is an exciting time because, again, it's a reminder about our t-shirts that are still available. If you'd like to buy them, you can certainly do that through the line, and Karen can put a link in the box so you can do that. Otherwise, there are two other ways you can do it. You can come on as one of the hosts, and we'll be happy to provide a t-shirt for you if you want to be the host of this jam, but also if you would like to sit in the crisis hot seat, that would be another way. But just a reminder that these t-shirts come in 2 languages, and you get a choice of these 5 different logos that you're welcome to place on there. All right. So we're looking forward to that because, as I mentioned a little earlier to the group before this, as we go down the road of implementing 988 and it becomes something that gets settled in, these are going to become historic treasures. So you want to get a hold of one of these t-shirts because it's really going to be worth a lot more money later on down the line. Okay, next slide, please. And we are now ready for our crisis hot seat. And I have to say that I have a very good friend and colleague who is joining us to be in the crisis hot seat. So I want to present Christy Malik. She is going to be joining us today for the hot seat. Are you okay, Christy?
Yes, I am. So we're keeping it all in the Nashville family, being in the hot seat.
For everyone else, Christy was not a part of the discussion on this. She does not know. She does not have inside information. Okay, so
I wish.
but anyway, Christy, here's a hot seat question. On November 11th of 2022, SAMHSA published the National Guidelines for Child and Youth Behavioral Crisis Care. The report describes a framework that states and localities across America can consider as they develop or expand their crisis safety net for youth and for families. So here's your question. According to this report, in NASH and others, a 2021 study of more than 500,000 youth who were physically restrained in the emergency department, Black youth were how much as likely as white youth to be restrained? You have a choice of 25% less, B is equally, C is 50% more, D is 100% more. You have options, Christy. You can wait and see how the audience, we're going to have to ask at this point. If you'd like to put your answers, we can process this. Christy, you have choices.
Yeah, let's poll the audience so and see what they say.
You'll go ahead and put that answer in the box. And I have to ask while we're polling the questions, Christy, did you have a feel for the question?
I'm leaning toward C, so we'll see. We'll see what the audience thinks as well.
Okay.
Yeah, so let's see. Yeah, so I think I'm going to go with the audience. We have a lot of subject matters in this group, so let's go with C.
All righty, so Christy has picked C. Is that your final answer?
That is.
Righty, well, let's go ahead and reveal the response. And the
Dum, dum, dum.
is
Oh, wow.
100% more.
Wow.
Now, this is based on important racial and ethnic disparities. In a study of more than 500,000 youth who were physically restrained, Black youth were twice as likely as white youth to be restrained. And it's horrible statistics, but it is, and I think it really sheds some light on what we just heard from our illustrious speakers about the importance of really listening and involving, because we can get a lot.
Yeah.
And I see from the chat, the same feeling is reflected by everyone. It's a sad statistic, but unfortunately, very much true.
But I think it's an opportunity that we can change those statistics.
Yes, and Christy, I want to thank you for being a part of this. The t-shirt is headed your way.
Yay! Can't wait.
Here's your opportunity. So let us know if you'd like to sit in that hot seat going forward. All right, thanks again, Christy. Let's move to the next slide, please. Okay, this is a reminder slide actually for the police ride along. If you've noticed in the Crisis Jam, we've started to talk to people who have actually had experiences of riding along with the police. So if you go to the next slide, what we're asking is that if you have been one who has ridden along with a police officer, one of the ways you can do it, if you haven't done it, is just to contact law enforcement to see if they even offer the service, or be aware that generally the residency for the municipality is required, but they will make exceptions for sometimes for stakeholders. And then some instructions on what to bring and how to do that, and understand that a background check may be necessary. But what we'd like to find out is if any of you have ridden already with police and would like to share your experience, please be in contact through us, through Karen. Karen, if you'll put a link in the box for them to get back in contact, we would love to highlight you on a future jam, because we really would like to see those experiences spoken out, so we get a better understanding of these experiences and what they really mean to folks. It's a powerful thing. All righty, let's go to the next slide, please. And we've reached now our data corner. And we have with us today for our data corner, Jason Lerner, and he's the Senior Director for 911 and Crisis Response with the University of Chicago Health Lab. So Jason, take it away, sir.
Thank you, Dr. Sims. And hi, everyone. I'm Jason Lerner, Senior Director for 911 and Crisis Response with the University of Chicago Health Lab, and I'm excited to be presenting to you today. What I wanted to talk about is some of the data sharing complexities involved in one of the projects Health Lab is working on, an evaluation of Chicago's Crisis Assistance Response and Engagement, or CARE program, a multi-agency partnership involving all of the agencies that you see here. In CARE, we're testing 3 separate response models, a multidisciplinary team consisting of a community paramedic from the fire department, a mental health clinician from the health department, and a CIT trained police officer. CARE also has a second alternative team consisting of the paramedic and clinician without the police officer. And finally, the city hopes to spin up a substance use focused team consisting of a paramedic and a peer recovery specialist sometime in the next month or so. It's still operating in just 13 neighborhoods, 1 shift per day, 5 days per week. And Health Lab is conducting an implementation evaluation to help the city identify issues before hopefully one day scaling up citywide. Next slide, please. So our experience with CARE is instructive when it comes to complexities with sharing crisis response data. These issues apply in particular with multidisciplinary response teams like those involved in CARE. We've been engaged with the city for over a year now in trying to obtain the data we need for the evaluation, and we are getting very close, but it's been complicated because it of course involves data from multiple agencies, including 911 dispatch, EMS, police, and the health department. This is something that we have a great deal of experience in, and we also have very engaged partners who want us to have this data. Yet it's taken over a year, and so you might ask why this is the case. Next slide, please. So first off, while the agency's ability to share their data with us is of course critical, perhaps an underappreciated analog to that is their ability to share data with each other. Operationally, CARE teams are riding around in vans together, and the issue of who has access to data from the CAD or RMS or police PDAs has come up many, many times. There's also a multi-agency leadership team we work with who meet multiple times per week, conducting quality assurance and other call review functions. So the question of what can be shared, particularly between clinicians and other first responders, but also EMS's ability to share medical data has been of great concern. Another example is, can police officers on these teams have access to clinical data? And likewise, are there any prohibitions on non-police team members having access to police data? If they can't have access to each other's data, then how does one prevent that when they work so closely together? So we think the question of whether and to what degree these teams should be able to share data is going to be applicable just about anywhere you have multidisciplinary teams working together. And these are concerns that all jurisdictions should be thinking about. Okay, if you advance the slide, that'll bring up the second part of the slide. Thank you. So related to this issue, in Illinois, there are state laws that further complicate matters. The EMS Act and the Mental Health and Developmental Disabilities Confidentiality Act have been on the books for years. And in the context of multidisciplinary response, they seem to be at odds. One requires the sharing of data and reporting for anything involving EMS, primarily to the state, but there are other reporting requirements as well. And the other protects patient privacy, including EMS activities. There's also, of course, HIPAA. But the issue here is the fact that CARE teams are treated as, quote unquote, interdisciplinary teams under the law. And so there are strict protocols which are even stricter than HIPAA. In addition to complicating data sharing among the field response teams, this has tangled up leadership review activities, the approval processes, you name it. So long story short, things like the city's QA process and sharing data between the team members was put on hold for quite a while. But after many months of deliberation, the city's attorneys determined that all data essentially needed to be de-identified. Now, Health Lab is a HIPAA compliant organization, and we take data privacy very seriously, but at the same time, much of our work, including our CARE evaluation, necessitates us looking across a variety of outcomes in multiple domains. In this case, dispatch data, EMS, clinical, police. And to do this, we need to merge and link individuals across agencies. And so typically what you would do is match on things like name, address, date of birth, but we can't do that here because the data need to be de-identified. So what did we do? In order to accomplish this in a de-identified world, we use a technique called hashing that allows us to both de-identify, but also preserve the ability to link. It's not quite encryption, but it may help to think of it that way. Essentially, we have an algorithm that takes identifiers like someone's name and transforms them into alphanumeric strings. We share this algorithm with the partners who can then apply it to their own data. That way, the algorithm, when the algorithm finds for Herman Munster at 1313 Mockingbird Lane in the EMS data, it creates a string in that data that will match the string for Herman Munster in the clinical data. I hope that makes sense. It's just a very broad overview. But that allows us to link the records across data sets based on the string that doesn't contain any identifiers rather than the actual identified information. It requires us to work very closely with our partners. We provide the algorithm to the analysts at the agencies. We coach them as necessary, and often we'll embed someone at the agencies to assist in that hashing process. That's the technique in a nutshell. The most important thing I think to take away from this is that it allows us to de-identify while preserving our ability to link across data sets from different agencies. And we think this technique can be adapted for many of the evaluations of these types of programs. Okay, that's it. Thanks everyone for listening. And now I think I'll turn it over to Matthew Goldman, who will wrap up the Data Corner.
Awesome. Thank you so much, Jason. Really appreciate your presenting on that. Data infrastructure is a huge challenge to really doing these evaluations successfully. And I think the methods that your team, including with Rebecca Newstetter and others, have developed are crucial for being able to generalize these kind of approaches and evaluations. So thank you so much for sharing on that. Just as always for Data Corner, we wrap it up with a couple publications and research findings. Here, I'm just highlighting a review of mental health emergency hotlines in the United States that was recently published in Psychiatric Services by Matthews and others. And also want to highlight a paper that highlights factors associated with police bringing children to a psychiatric emergency room. This is very relevant to the hot seat question that we just had and was highlighted in the SAMHSA report. And so that's the original publication that also was just published in Psych Services. So thank you, Karen, for putting the links in the chat. A couple other notices regarding NIMH funding opportunities to continue to advance crisis services research. And with that, I will hand it back off to Brian.
Thank you, Matthew, and thank you, Jason, for that incredible information. Jason, keep a hold of that thought with regards to that hashing. I think you're going to get a lot of questions in that regard, because that's something we've heard a lot about in terms of what the states are struggling with in that de-identification portion. But thank you both. So let's move quickly into our SAMHSA update report, and we have John Palmieri who will start us off. Go ahead, John.
Thanks, Brian, and thanks, Jason and Matt. I'm really interested in what you had to say. We are very much interested in enhancing data collection and identifying some core technical functionalities across the crisis system. And so your comments are extremely insightful, and hope that we can kind of continue that conversation and build on that. So with some quick updates, I know this is already flagged a couple of times in this jam today, but there will be more of a deeper dive on the youth crisis document with Dr. Shaw and Dr. Everett at the beginning of January, and also highlighting that we are seeing some positive movement with our enhanced Spanish language call access. And so hopefully be able to report out on that a little bit more coming soon. With respect to the Bipartisan Safer Communities Act funding, we are wrapping up our review, both of the tribal 988 applications and the supplement applications that went out to states and territories. And so we should have some announcements forthcoming about those awards, again, really intended to enhance workforce infrastructure needs for 988 response and support. some of you may be aware related to the tribal work that Washington State initiative for a dedicated line for tribal citizens, tribal nations, tribal organizations went live earlier this month. We are having a next phase of a convening. So we've had a few convenings with NASHBID and a number of other partners supporting 988 implementation, and now really focused on kind of drivers of longer term crisis transformation, technology, equity, communications, workforce, financing. That convening will happen December 12th, 13th, and there will be some more information and invitations going out about that. And then finally, wanted to flag that we are engaged in some conversations with Canada. You may be aware that Canada is also in the process of launching a 988 initiative. And so we are going to be working closely with them to ensure successful integration of services, particularly attentive to some of the issues on the northern border where coordination is going to be critical. And then I'll just pass it off to Richard McKeon.
Thank you, John. Just wanted to make one or two comments that when the jam started today, one of the things that was featured was the unfortunate story regarding a youth at risk for a student at risk for suicide, and the Yale apparent policy around not being able to remain at school. This is an issue that has come up in the past. There was a lot of attention given a number of years ago to similar concerns regarding George Washington University that got a lot of attention. So I just want to remind people that SAMHSA has a campus suicide prevention program. And in fact, George Washington University received one of those grants. We work closely with them regarding their policies and activities. And obviously what we want is for a student who is thinking about suicide to be able to reach out for help without concern that they'll be forced to leave school, because the circumstances that might require that, or if they have to leave school, that it's a consensual decision between the university, the student, the family, etc. So there are also other organizations such as the JED Foundation that has worked closely on these issues in the past. So I just wanted to mention those things. I'm certainly not expert on the situation at Yale, but it is concerning. And as a general principle, people feeling that they can hear the word suicide used in a conversation and remain engaged and explore rather than to distance, avoid, and to try to use mechanisms to have someone else deal with the situation is certainly what is in the interest of suicide prevention among youth nationally. So that was the main thing I wanted to to emphasize, and to remind people that SAMHSA has a team that works on campus suicide prevention across the country, and that these issues are certainly a central concern. Thanks.
Thank you, Dr. McKeon, and thank you, John, for your leadership through SAMHSA. I want to move ahead to our NASHBID report, and for today, we'll be favored with Michelle Zabel, who is going to do a presentation on the safe place to be. Just a minute or two on that, Michelle.
Yep, I was given 3 minutes and I'm going to stick to it. Thank you for having me. I am Michelle Zabel. I'm currently at University of Maryland, Baltimore, and wanted to let people know that in the next couple days, we'll be moving to the University of Connecticut, and we'll be looking forward to keeping connected with all of you as we work on behalf of kids and families and customizing services for them in this great opportunity we have. We're also thrilled because Nashville has partnered with us to create this document, which is intended to be a resource to all of you. And I want to call our colleagues out from Healing Through Justice. I think the presentation that you did today was so on point for what needs to be happening locally and on behalf of kids and families. And I think this document actually provides a nice combination, a bookend, if you might, for states and systems that are designing and refinancing and remodeling what crisis systems should look like. So I've had the privilege of working on designing, installing, and implementing crisis systems for kids for over 20 years. And I can't believe we're really here talking about how that should look across the country. I wanted to call out that the document itself is, in essence, kind of a toolkit for that last piece of SAMHSA's guidance document, which goes through the full continuum. This is the part that's about responding, right? And what does stabilization look like for kids and families? This is built off of not only research literature, but the experience, so practice-based evidence of multiple states across the country who've done early adopter work of what most of them call mobile response and stabilization. What's necessary once a team goes out and responds? What's the stabilization look like? So it really has been because of SAMHSA's investment that we know this much. Early on through system of care grants, we had states and locales like Wrap-Around Milwaukee and Connecticut and New Jersey use their system of care grants to create these models and enhanced continuums. SAMHSA also funded a convening that happened over the course of 2 years where 26 states came on site and did mobile response ride-alongs with teams, as well as an opportunity to discuss what customization does look like for kids and families. And right now there are 6 states engaged in a quality learning community where they're working hard to define together what their design needs to look like, what the financing needs to look like, and what the data collection needs to look like for their systems. And I do want to remind people that when we install what we have seen across the country, when we install mobile response and stabilization or crisis stabilization services, that the states overall start reaching back, right? It's not just our teens and our young adults and where some of the data has been presented today in terms of our suicide risks and concerns we have, but we see 3, 4, and 5-year-olds getting families with 3, 4, and 5-year-olds calling for response and assistance. And so when the child, youth, young adult system talks about what does a crisis stabilization system look like, we are reaching back and finding families in best case scenarios that we can support early on. And you'll find all of that outlined in this document. So I know I'm preaching to the choir, but I want to remind everybody, and the document makes this point again and again, that building a crisis response model off of an adult model, that retrofit does not happen. Children are not little adults and they do need something different. That in the children's system, one of the things that is paramount is that the crisis is defined by the caller, whether that be the young adult or the parent or the caregiver, that and that the majority of the time, unless the parent or caregiver or young adult does not want it, that a mobile model is the best model. That anybody here on this call who has children themselves or children in their lives knows when your child's escalated, you're escalated. And so de-escalating the adult and then it getting to the kid is not a model that in the children's system we have seen work. And so mobile models are really important in the design. And that those workforce that go out, generic models of workforce development do not work for children, that there needs to be customized screening mechanisms, assessment tools, and the workforce itself needs to be trained. And in our rural jurisdictions and frontier jurisdictions, that may mean that it's not a person coming to the table that is actually, from an undergraduate, graduate, or whatever certification trained, but that it does become incumbent on this actual crisis stabilization system to provide support so that those folks that are coming know how to actually work with a child and a family. And that it's important in all that we've seen across the country that stabilization is actually taken very seriously, that it's not just the mobile model, but it's actually stabilization services. From what we've seen in states for the last, let's say 20 years, 6 to 8 weeks is what's really important in the design. So there's so many more things that I should highlight. I'm going to ask you to just read the document, disseminate the document, use the document. Please reach out if you have questions. There's plenty of early adopter states out there that love to share their experience and their learning. We know there's a tremendous amount of innovation that needs to occur on behalf of kids and families. But again, I'll say it and say it and say it. Retrofitting systems on top of adult systems leads us to where we're at today, which is a crumbling system and kids in crisis. It's important that we take this opportunity, and those that are responsible for design and financing and installing and implementing take very seriously that this chance we have right now is going to actually change what it looks like for kids and families across this whole country. So please invite, as our Healing Through Justice friends said, invite children, invite young adults, and invite their families to the table, along with the systems people that are responsible for kids systems in your state and in your locales. Without them at the table, there will not be a design that meets their needs. So thank you for having me. Reach out if you want to talk more. I appreciate being the opportunity to be here.
Well, thank you, Michelle. And again, so much information there. We've come up on our end of our time, but before we actually cut off, I just want to make you aware that we will not have a crisis jam next week, but be on call for the following week, where we'll have Tansy McNulty doing a mobile crisis directory. So to each and every one of you, I want to thank all of those who participated in the jam. My apologies to those that we could not get to for today, but everyone have a wonderful rest of the day, and we look forward to seeing you next week.